Thank you, Hiranya. Thank you for giving me opportunity. So, infantile esotropia, importance of precise diagnosis. So, if we talk about the definition, it's the esotropia developing within the first 6 months of life, otherwise a normal child, with no refractive error or limitation of ocular movements. Earlier, this infantile esotropia named as congenital esotropia also, but most of the time it's developing within the 6 months, so that it's renamed as infantile esotropia. This is just a picture. So then there are many esotropias, as we know. Then we to diagnose precisely, first we need to know the differential diagnosis, right? So a differential diagnosis comes as pseudoesotropia and sensory esotropia and accommodative esotropia and congenital sixth nerve palsy and congenital fibrosis of extraocular muscle syndrome, Mobius syndrome, and esotropia associated with neurological diseases such as cerebral palsy, periventricular encephalomalacia. So then all these diagnoses comes with infantile esotropia. So then we need to differentiate each to have a proper diagnosis of infantile esotropia. So why is it important to diagnose this precisely? Because mainly the infantile esotropia management is primarily procedural intervention, either surgery or injection of botulinum toxin. So when you compare with the other differential diagnosis, mainly non-interventional, so then it's important to diagnose properly. So what are the characteristic features of infantile esotropia? Then as the definition, it is onset within first 6 months of age, and deviation is typically constant and committant and large angle, mostly more than 30 prism diopter base out. And you may see mostly cross fixation or crossing eye. That means cross fixation means when they see to lateral or abduction, they focus fix with the opposite eye, and you may see the ipsilateral eye abduction restriction. But if you patch the eye or close the eye, you will see the full abduction. And other things are associated with latent nystagmus, DVD, and inferior oblique overaction. You may see those things later within first year of life. And other thing, no significant hypermetrophic refractive error. It should be less than 2 to 3 diopters. So these are the characteristic features, and this is just the second down photo is a cross fixation. And so how are we establishing diagnosis? The history is the most important thing, and we need to check with the parents the history of the first presentation. And sometimes you may not get a clear-cut timing, and then you can ask about the photographs of the child, the old ones, and that's very important to like, you know, according to the definition within 6 months, so is it developed within 6 months. Another thing is we can ask about the risk factors like prematurity, birth weight, and those things also comes. The prematurity is one of the risk factor. And also, then, as I said, the infantile esotropia usually occurs in otherwise healthy child. So then we need to exclude, ask him by history whether there's any complications of birth, any developmental delays, and about the milestone and other health issues at the child. And also there is a factor, familial inheritance also associated with infantile esotropia. So this comes under history and examination. So we need to have a full ophthalmological evaluation with dilated funduscopy, where we can, one thing, pseudo esotropia, then that is like a wide nasal bridge with epicanthal folds. By examination we can rule out it. And at the same time, sensory esotropias like media opacities, cataract, maybe retinoblastoma or any PHPV, those kind of things can be excluded with proper examination. And then it's important to evaluate the visual acuity. Usually, they can be amblyopic, about 40 to 50%. So at this, like less than 1 year child or less than 6 month child, it's difficult to assess visual acuity, right? But you can see the fixation and following, and also if there, you can suspect amblyopia if there's a fixation preference of one eye, right? And also you can do the preferential looking test or VEP testing to assess visual acuity. And then we need to rule out accommodative esotropia, which we can get early as 6 months of age. Those things can be done by full cycloplegic refraction. Usually in infantile esotropia, it's less than 2 to 3 diopters hypermetropia, which is age appropriate. And then when it comes to the assessment of strabismus proper, as I said, it is usually deviation is large angle, more than 30 prism diopters. So it's difficult to sometimes to do a proper cover test and uncover test, but you can just assess also with the Hirschberg test, the corneal reflex. And other associated findings like cross-fixing. And usually extraocular movements are full, there's no limitation, but sometimes when they have cross-fixation, you may see that abduction deficit that you can do either patching of one eye or doll's eye movements, and you can elicit the abduction. And also can be associated with latent nystagmus and DVD in more than 50% of children, and inferior oblique overaction more than 70%. Initial, very early stage, you may not see DVD and inferior oblique overaction, which is developed later. Then with all this history examination and the assessment, we can rule out the other differential diagnosis. Then that's the, as I earlier said, like a precise diagnosis is more important because infantile esotropia is primarily a procedural intervention, whereas others may not be, right? Sometimes you may give spectacles or we may observe, and if there's any other neurological things, you go in different directions of assessment and management. So this is why infantile esotropia is need to diagnose precisely and also the management, when it's just touch management, it is just two major interventions we do, that surgery and the botulinum injection to medial recti muscles. So in surgery, usually it's early surgery is recommended at least before the age of 2 years, thinking that there is a benefit for development of binocular function and stereopsis. So then you can do this range of surgery time like 6 months to 2 years, better before 2 years. And mostly we do bilateral medial rectus resection, but still we can do the bilateral lateral rectus resection or medial rectus resection and lateral rectus resection. That depends on your choice. But majority we do bilateral medial rectus resection. And what's the other way of, kind of a newer way of intervention is injection of botulinum toxins to medial recti muscle to, temporarily paralyze or relax. So this is also frequently performed in children now, mainly for the small to moderate deviation like less than 40 diopters, and dose can be like 2.5 to 5 units, or can maximum go up to 10 to 12.5. And also this will help straight the eye and improve the fusion. But only thing is, action will last about 2 to 3 months and may need multiple injections. So in a summary, so diagnosis of infantile esotropia precisely more important because it is management is procedural intervention when compared to the other diagnosis. That's right. Thank you.